Greetings from Bolga. Today we are going to discuss Videolaryngoscopy session 2, Principle of Videolaryngoscopic Intubation. So before viewing this session, I request all the viewers to go through the session 1 Videolaryngoscopic Basic, Videolaryngoscopic Geometry, in which we had discussed about the designs of videolaryngoscope, curvature of videolaryngoscope, and how the curvature is having impact on laryngeal view, manipulation of tube, and ease of insertion. So again, we request all of you to go through the session 1 first and then go ahead with this session 2. That is about the videolaryngoscopic intubation. Principles of videolaryngoscopic intubation. So we have discussed about the laryngeal exposure. We have discussed about where the camera is placed, videolaryngoscopic camera is placed when videolaryngoscopy in situ. So when videolaryngoscopy in situ, camera takes the position into the pharynx to take the image of larynx. So it's looking from downside up. That part already we have discussed in our session 1. So now, and that is how it provides the laryngeal view. So in today's session, we are going to discuss how to make entry into the larynx and the passage of the endotracheal tube. And if you look at the most of the evidences, most of the articles, it's mentioned that view is easier to get with the videolaryngoscope, but to get into the larynx, intubation is a bit tricky. Why it is so? So in direct laryngoscopy, when you are using a direct laryngoscope, it creates a direct line of sight from our eye to larynx. It's looking from upside down. And at the same time, we are also creating a channel for the passage of the endotracheal tube. So this is line of sight. But when we are using the videolaryngoscope, so when videolaryngoscope are in situ, the camera takes the position on the line joining the primary curve and secondary curve that we have discussed. We had discussed in session 1. So as videolaryngoscope takes the position here and takes the image of larynx, so line of vision is this much. So we have to, when we are intubating, so with a direct laryngoscopy, there is a channel for the passage of the endotracheal tube. We can directly insert the tube into the larynx. But when we are using the videolaryngoscope, the endotracheal tube has to maneuver along this primary curve, along the oropharyngeal curve, or along the curve of the tongue. That requires pre-shaping of the endotracheal tube as per this curve. So with different videolaryngoscope, you have to pre-shape the endotracheal tube as per the curve of videolaryngoscopic blade or as per the curve of oropharynx. Or in a simple sense, if you are making a J-shaped pre-shaping of the endotracheal tube with the pre-shaped delay, that increases the ease of insertion of endotracheal tube and your success rate of videolaryngoscopic intubation. Now, important, suppose you are using a not preformed, you are not using the preformed stylet. If you are using the standard stylet, then you have to make it pre-shaped by making it J-shaped like this. So how to make, from where to bend the tube, pre-shaped tube to make a J-shaped angulation? So tube has to be bent from the proximal end of the curve, from here. And you have to bend 60 to 80 degree. In most of the cases, 60 to 80 degrees is sufficient. In rarely, you have to bend up to 90 degrees. So again, when you are pre-shaping the endotracheal tube with the stylet, that pre-shaped tube to be bent from proximal end of the cup 60 to 80 degrees to make it J-shape. So when you are inserting a tube with a videolaryngoscopic camera, the tube passage is as per the primary curve. as per the oropharyngeal laryngeal curve. Now coming to the third part, passage of the endotracheal tube. Again, with the videolaryngoscopy, we are not creating a channel for the passage of the endotracheal tube. So endotracheal tube has to be maneuvered along the primary curve and secondary curve. Means we have to make the path as per the oropharyngeal laryngeal curve, laryngeal tracheal curve. That creates a difficulty. Suppose this is a videolaryngoscopy in situ, and trachea is not a straight tube. Trachea is going towards right and to posterior layers goes towards the carina. And this creates a disparity of angle between these two. So if you try to pass a stellated tube, is going to hit the anterior tracheal part or anterior laryngeal area. It's causing impingement, which increases the chances of trauma. So when you are passing the stellated tube, you have to keep the tip of the stellated tube at the larynx and just advance the tube at the same time withdraw the stellate little. That is one solution. Or reverse loading of the tube, which increases the chances of passing the tube inside the larynx with less trauma. Or using Farker flex tube. So I'm going to post the video of all three in a couple of weeks. So as you are traveling from here, as we discussed in the session 1, you have to travel down. Once you cross, so trachea is going down. So same way you have to travel down with the tube. That's create a big problem. We'll discuss that part in a coming session of troubleshooting with the videolaryngoscopy. Another problem with the video, another important thing, when you are using the anatomically curved blade or means hyperangulated blade or J-shaped blade, all the videolaryngoscopic blade insertion has to be done in the midline. And now suppose you inserted the scope. Now you have to insert the tube, pre-shaped tube. So many times you won't get the space here. You have to generate the space. And pre-shaped endotracheal tube with the stellate should not be inserted in the midline. You won't get the space. Look, here I am not getting the space to go in. So pre-shaped endotracheal tube has to be inserted from the side of the mouth. This is wrong technique. From midline is wrong. It should be from the side of the mouth, angle of the mouth, and then it should be rotated towards the laryngeal inlet. This is the ideal way. It should be inserted from the side of mouth and it should be rotated towards the loop. Here I am inserting the endotracheal tube with the anatomically curved blade from the angle of the mouth. And I am also generating the space by shifting the mandible caudally. So from the angle of the mouth and rotating towards the larynx. This is the way you should insert the tube. Again repeating. And so again repeating it, look. I am inserting the tube from the side of the mouth by generating the space. Generating the space, inserting it from the angle of mouth and then rotate it towards the larynx. Now, common mistake all of us are doing when our tip of the endotracheal tube, stellated tube is reached up to the larynx, we try to pull out the stellate upward. That creates a lot of resistance and many times it decreases your success rate. You're not able to intubate. You get or it increases the chances of trauma or laryngeal loop. As I'm taking it out upward, creating a lot of resistance. So this is wrong technique. So if you are removing the stellate upward, that is wrong. You should not remove the stellate upward. So if you want to remove the stylet, ideal way to remove the stylet, you should remove the stylet, maintaining the oropharyngeal part caudally towards the patient leg end. There and then your tube will go towards the larynx. So this is the ideal way. You should remove the stylet caudally, like this, which increases the chances of success and decreases the chances of trauma. Now question is that boogie can be used instead of stylet. Boogie may not be a solution when there is a difficulty with the anatomically curved hyperangulated blade, because boogie can't take the actual angle or shape of the oropharyngeal curve, angle of the oropharyngeal curve. It can't take. But if you are using stylet, stylet can retain the angle of oropharyngeal space, oropharyngeal curve. So that's the reason with the hyperangulated or anatomically curved blade, you should always use stylet, not the boogie. Now another questions. Which type of tube is having easier intubation or higher success rate? So if you are using the PVC tube and if you pre-shape it, because of it retains shape, during insertion there increase the chances of impingement at the laryngeal inlet with the standard PVC C-shaped tube. But when you are using wire-reinforced endotracheal tube, which decreases the chances of impingement with videolaryngoscopic intubation. So now, what are the clinical steps of videolaryngoscopic intubation? First thing, position. Patient position either in a neutral or RAM position. Sniffing position is an independent predictor. It's an independent predictor for difficult videolaryngoscopy that we'll discuss in the next session. So always neutral or RAM position, specifically anatomically curved blade. All the blades, videolaryngoscopic blade, to be inserted in the midline, looking in the mouth, parallel to hard palate and soft palate. Once you insert the blade into the oropharynx, then you have to rotate the blade as per the oropharyngeal curve, and then you have to change your eyesight from mouth to screen. Then you have to centralize the image. Now, once you centralize the image, then third step is you have to look in the mouth again. And looking in the mouth, you have to insert the styleted blade from the angle of the mouth. This will prevent the posterior pharyngeal wall trauma. And then you have to rotate the pre-shaped endotracheal tube towards the larynx. Then again from the mouth, you have to look at the screen. And looking at the screen, keeping the stylet at the laryngeal inlet, you just have to advance the tube inside the larynx. So it's a four-step technique. First, mouth for videolaryngoscopic insertion. Second, screen for aligning the laryngeal image. Third, looking at the mouth for inserting the tube. And then advancing the tube into the larynx, you have to look at the screen. So this is a four-step technique. Mouth, screen, mouth, screen. In short, hyperangulated videolaryngoscope, surgically anatomically curved blade, require pre-shaping of the endotracheal tube. It requires hand-eye coordination. Create a difficulty in making entry if you are not experienced to manipulate the tube or use the pre-shaped endotracheal tube. Increase the time to intubate. To overcome this problem, few companies come out with the channel videolaryngoscope. And most of the channel videolaryngoscope are J-shaped videolaryngoscope. So what they did? So there is a slide slot to load the endotracheal tube. And again, this assembly to be inserted in the midline. And once you get the laryngeal view, you just have to advance the tube from channel to the laryngeal inlet. And because of only two-step technique, it significantly reduces the time to intubate in comparison to non-channel anatomically curved blade. So it's only two-step technique. Look in the mouth, insert the blade with the loaded endotracheal tube, and then advance the tube inside the larynx once you get the image of larynx. And that significantly reduces the time to intubate in compared to non-channel videolaryngoscopy. So channel anatomically curved videolaryngoscope makes the line of vision and line of insertion one. It do not require stylet, and that's the reason it requires less time to intubate. So now coming to the session 3, that is about predicting the difficulty with the videolaryngoscopy and decision making with the videolaryngoscopy. Will take. I'm going to upload this session by next week. Till that time, goodbye and thank you.